Let me give you control here.
All right, let me show you a couple of different kinds of things today. This is a lady that apparently had this pacemaker placed out of our state a couple of weeks ago. So I'll give you a few moments to look at this new pacemaker and its associated leads. Obviously, I'm showing you the frontal and the lateral projection. And let me now show you the frontal projection. Mag up a little bit. So the finding here in relation to the right atrial appendage lead is the fact that it is hanging straight down within the right atrium, and the usual curve of it is not present. So typically it curves anteriorly, but it has a curve which is not present here in the usual way. An interesting finding on this lateral projection is that while we are kind of used to seeing a little motion-related unsharpness of the leads in the beating heart, there's a conspicuous amount of blurring of the atrial lead. So it is bouncing around in the atrium a lot more than the right ventricular lead is. And of course, it's because the tip is dislodged from the wall. So I'm not sure if I've noticed that before, but if you want to give that the name of, give it a name like excessive bouncing of a lead, and you happen to look at the lateral projection, I'm not certain I would have picked that up right off the bat, but given what this person has, that is a dislodged lead. That makes perfect sense. So I don't know if I've noticed that before, but that's kind of cute.
Yeah, we had a similar case. We had a comparison where it had popped out of the right atrial appendage. I don't recall if we noticed the bouncing, but that's, I've seen it when they're both bouncing. It tells me the patient's probably tachycardic. But in your case, you didn't have a comparison, so it might be easier to overlook this. But yeah, we had one where it was pointing up on the previous, and then at the time the patient presented, it was pointing down.
Straight down like this one. Yeah.
Howard, I think it also depends on what part of the cardiac cycle you get. So this is probably atrial systole that's causing the blurring. I've seen, one of the things I've seen, for instance, with Swan-Ganz catheters in an obese patient that requires a long exposure, is that sometimes the catheter is sharply defined in the right atrium, is blurred in the right ventricle, and then reemerges sharp in the pulmonary artery. And that was, there was a ventricular systole that blurred it in the ventricle. The atrial part, you know, wasn't subject to that, when the pulmonary artery part hadn't seen it either.
Oh, yeah. So they will have to fix this one and reattach it to the atrial wall. This one is a rather interesting presentation of something we've seen before. I'll show you both the frontal and lateral projections of the chest. In looking at these, it's pretty obvious that there is a large opacity in the basal and medial and posterior basal left hemithorax. I don't know if the patient had symptoms referable to this, but it's a rather striking imaging observation. So what is that? Here is the CT done a little later on the same day. I'll put up the axial and those, and see if I can get those to show up properly, as in like that. So here we go in the basal left hemithorax. That large opacity looks like that, and we'll scroll through it. It's pretty apparent right off that it is of low attenuation. Indeed, it's of water attenuation. And In judging what it's doing, it's sitting there, it's pushing things aside. So for example, here, one can see the esophagus is pushed rightward by it. But otherwise, it's a very circumscribed lesion. There's a little compressive subsegmental atelectasis adjacent to it. But otherwise, it blends rather nicely, or at least it's contiguous rather nicely with other structures. So part of the heart and the aorta is close by, but otherwise aorta-containing cystic structure. So this, of course, did come out, and it is indeed a mesothelial lined cyst. So very consistent with the so-called coelomic cyst, a mesothelial lined cyst, depending on how you choose to describe it in reference to its origin or its histology, but certainly consistent with a pericardial cyst, albeit an unusual location, but for sure it is a mesothelial lined cyst or a coelomic cyst. So I'm not sure if I've seen a pericardial cyst in that location.
Why can't it be a foregut duplication cyst?
I suppose it could be, but aren't those typically associated with GI tract epithelium?
Yeah, it shouldn't be lined. If it's lined by mesothelial cells, it either has to be a pericardial cyst or cyst associated with the pleura. It has to be one of those two.
Yeah, some coelomic cavity cyst, derived cyst or coelomic cyst.
I've never heard the word coelomic, but I'll use that in my next dictation.
Yeah, I mean, that's basically where these originate from. So you basically have the embryonic coelom. So we have the pericardial, the pleural, and the peritoneal. And if one of those is, in a sense, pinched off and becomes a cystic structure, then it could be one of these. So depending on where you see it, that's the way I tend to think about it as to what to call it.
Now, do you think any of my referring clinicians will know what I mean if I say coelomic cyst?
Okay.
Nope, it's just going to generate more work for you.
But they won't, and they won't know how to spell it either.
Yeah, let's just assume I'm crazy. Yeah.
So now, Howard, there's no sense that this thing arose in the upper abdomen and came up through a hiatal hernia, right? We're not seeing.
Take a look at that. I didn't notice that, and I don't have the op note there, but it was certainly, there's no description that it came from below. It was just exactly what you see here. They spent some time taking it off structures and taking it out of the chest. After they punctured and took the fluid out, they basically dissected it away from adjacent structures and it all came out.
And what sort of CT numbers did you get out of it? Was it?
Okay, so we can just say pick a spot there. I think he will do it. So here we're in the region of 0, right there, from that location. And here, 8. So pretty much water.
Watery cyst.
Yeah.
Very interesting.
Yeah. This is the abbreviated path report right there.
Huh.
I actually spoke to the pathologist and kind of warned her that we definitely have a cystic structure, and I was thinking of either a foregut cyst or a pericardial cyst, and we talked about the mesothelial lining, and she looked for the lining and described it as that. All right, let me show you. This one is interesting from several points of view. So this is a young person that presented with, unfortunately, this very large combination of a mediastinal mass and a large amount of right pleural fluid. And what is also notably present is pretty much complete obstruction of the superior vena cava. So anterior mediastinum, no hint of contrast median in superior vena cava. You can see the collateral pathway. So a dominant one here is left superior intercostal vein. We have paravertebral veins, contrast median going up the azygos vein, cannot go into the SVC. It just has to go other places. And then when we go down into the abdomen, what is really interesting that we begin to see the IVC. So there is passage of contrast via collaterals to the IVC. But here's quite interesting where there's clearly a communication between, I guess, phrenic or hepatic surface capsular veins with some portal vein branches, I would guess. So this isn't the classic segment 4, the hotspot we usually see, but rather is a hotspot in the posterior part of liver, getting some collateral flow from, I can't tell for sure, phrenic versus capsular surface veins or combinations thereof. So that's an interesting hotspot right there in the context of central vein obstruction, which is substantial. And there was some discussion initially as to whether this was a Hodgkin lymphoma versus some other lymphoma. They had to get an additional biopsy of it, and it turned out ultimately looking at the biopsy and flow cytometry and looking at all the cell surface receptors, as you can see there, they ultimately interpret that as an anaplastic large cell lymphoma, ALK negative, large anaplastic large cell lymphoma. Bad actor, I think. Has anyone seen this particular hotspot location? I know they can be located in other places other than the classic one up here, segment 4, I think it is.
I haven't seen it there. That's a nice example, though.
Yeah. I don't get lower than this. Here's another collateral coming across trying to get to the IVC, undoubtedly, and a lot of paravertebrals. All right. Let me show one more. This is a patient I saw the other day, and it's from the clinic. It just said, I can't remember, it might have said something like dyspnea or shortness of breath. And I wasn't sure of the finding. It did turn out to be right, but it's pretty subtle, so I'll show you what I saw. Got a bit lucky here and suggested that there was a little Pneumomediastinum by virtue of seeing really subtle streaks of air up here, I thought, and I wondered here whether there was displacement of pleura by mediastinal air. So that is indeed the case, and I'll show you that the CT that was subsequently done does show the Pneumomediastinum. It's not a lot, but there is. Now, one interesting finding here is in thinking about what this all means, what's really conspicuous is the amount of intraluminal material consistent with mucus in airways in the upper lobes. And in fact, the more one looks, the more one sees, particularly down here, intraluminal material in the airways, but it's quite diffuse, and some bronchial wall thickening. And some other interesting findings here, subpleural interstitial edema. So that certainly goes along with the Macklin phenomenon as the etiology of the Pneumomediastinum. And that together with the airway disease, one should think of asthma, certainly an association between asthma. This was a little perplexing because this seems to be more than could be just subpleural interstitial emphysema. It really looks like there's a small pneumothorax there, which I found perplexing when I found out about that. So that's rather curious. But the patient does have asthma, by virtue of this note at least, history of poorly controlled asthma. So everything fits very nicely, except perhaps for this right down here, which seems to be a little pleural air, I think, compared to this one, which is definitely consistent with subpleural edema related to an interlobar fissure.
So Howard, on cross-section, can we track that medial posterior air collection back up to its relationship with pulmonary ligament by any chance?
Okay, so let's see if we look around the esophagus. There it is.
Can we go up higher?
And we go higher.
Seems to peter out before we get to inferior pulmonary vein.
Yeah, it's really just in that inferior pulmonary vein is just below that.
We'll go down a little bit there. So it looks as if there could be some gas there in the intersublobar septum there on the right, just below the inferior pulmonary vein, right along there.
Right there.
Yeah.
So that could be a little interstitial emphysema right there. But this is a bit odd, isn't it?
And I just wonder if this is subpleural gas along that mediastinum. It's not really in the pleural space, but maybe adjacent to the pleural space.
Maybe just an unusually large amount of it in the subpleural interstitium of lung.
Yeah, just given the strange, the way it sort of hugs.
Yeah, we may never know. Because usually I wouldn't think that subpleural interstitium is that capacious, as opposed to, say, this one.
Yeah.
So it is a little odd. It's certainly a nice teaching case, and I think that the explanation of the Macklin phenomenon, acute asthma, is quite fine.
So there used to be this entity in the plain film days called air in the pulmonary ligament. And it was particularly seen in children, typically after a fall. It's like a kid would fall out of a tree and there'd be this medial gas collection that sort of hugged, you know, the lower mediastinum, and people said, well, what lives down there? And they said it's the pulmonary ligament. And so they would call this sort of thing air in the pulmonary ligament. But I never had any CT examples of that phenomenon. I have a feeling that it was some sort of a medial gas collection. And this is very reminiscent of what people were describing in those days of air in the pulmonary ligament. So
yeah,
I think this is a funny either medial pneumothorax or subpleural gas dissection.
Yeah,
perhaps to the funny, you know, this sort of this very small radius bay of lung going in along that esophageal recess. I wonder if it's the shape of the lung that promotes that kind of subpleural gas collection potentially.
Yeah. One argument that this isn't in the pleural space is the fact that when we do have air in the pleural space, often we see the pulmonary ligament and we see there's gas anterior to it and gas posterior to it.
Good point.
The fact that as I scroll there's no hint of actually seeing the pulmonary ligament, I think speaks a little bit to the fact that this isn't pleural space air, I suppose.
Now, the other thing it could be is Pneumomediastinum that's concentrated there.
In some funny fashion. Yeah, I don't know.
Again,
Yeah,
maybe the traction on the lung right there, sort of pulling it open the pocket in the mediastinum. I think that's actually a more plausible explanation that this is a localized pneumomediastinum because there's more traction when the lung has that smaller radius. That lung is pulling away more strongly by, I think that's Laplace's law or somebody like that.
All right, Jeff, those are mine.
All right, thank you, Howard.
Thank you.
I see Seth and Travis are on. Would either of you like to go next?
Yeah, I can go if you want.
All righty.
All right, so let me get this thing out of the way here. This was a nice case. Just do this in order. So not a subtle finding on radiograph. Kid came in with severe chest pain. So has this large mass sitting in the mediastinum. You can actually see that there's the hilum behind it. So and the paraspinous muscles and stuff look good in paraspinous. So it's probably anterior mediastinal, which was confirmed. And then here is, let me just make sure I have the right one first. Nope, that's the, so here's the study that I read. I actually read most of his studies. And you can see that it is a relatively homogeneous, although high in attenuation. It was around 40 or 50 structure in the anterior mediastinum. I think it often looks better on the thicker slice images. You get less noise. And it just looks like a cyst. I mean, it's smooth, it's lobulated, it's not displacing structures. Yeah, it's higher in attenuation, but it just looks like a cyst. But nonetheless, he's a young kid. He's in pain. There's a little dot here, maybe. I mean, I think we've all seen plenty of cystic teratomas or other cystic tumors. And I have to say, one thing I did miss was, I thought that, so he has thymus here, thymic tissue, and I thought this was just some thymic tissue down here, kind of low-hanging thymic tissue. But in retrospect, that was probably some fat stranding. So I called them up and said it's probably a cyst, and they're like, "Oh, he's in a lot of pain." And I said, "Oh, it could be infected. It could hemorrhage." He has a small pleural effusion, which is abnormal. Anyways, they admitted him, and they were going to take him to surgery for it. And this was his follow-up study that he got like 2 days later. And you can see he was in severe pain, and they wanted to exclude PE, which there wasn't. But now you can see there's a dramatic amount of fat stranding surrounding this lesion. It's unchanged in size, but you can see all of the inflammation, dramatic inflammation in the mediastinum. It's developed good size effusions on the right greater than the left. And, I called it the surgeon. I said, it's probably, I still think it's a cyst, but, and it's probably got infected. And he's like, yeah, the white cell count is skyrocketing. I think his white cell count went up into the 20s, and he's in a lot of pain. And I said, yeah, it's still likely a cyst, but, you can always get an MRI if you want to confirm that. I don't think it's a bad idea. So he got an MRI, and you guys hold on for, let's see if this will load quickly. Takes a little bit. So you can see that this lesion is pretty darn heterogeneous on the SSFPs. Remember, SSFPs have some T2 weighting. So, and there's areas here, some lonculations. Doesn't look too bad. I mean, it's heterogeneous. It doesn't look like a simple fluid. You can see the rim of this thing. You can see some of the inflammation, this signal here surrounding it. And I'll show you a couple other, wasn't the best looking study, I have to admit. But here is the T1 post. And you can see that this thing almost looks like an abscess now. And he basically went to surgery, and the surgeon said it was a cyst. It was a walled off cyst, and it just looked very infected and inflamed. And he went in there, he took out a lot of the fluid, and it was he said some of the locules were filled with pus, others were filled with blood. Now we're waiting the final path, but I'm assuming that this is an infected bronchogenic cyst. We know that the other cysts tend not to get infected. I'll update people if the path comes back and says anything different. But I've only seen a few bronchogenic cysts get infected, and I have to say, each time I've seen that, the patients are very symptomatic and in a lot of pain, which this patient was as well. I'm trying to find one of our T2s that shows how ugly this thing was, or even if we can call this a T2. I'm embarrassed to show you some of the quality. I actually had to change our MRI protocol after seeing this study because it just looked horrible. And this image doesn't look much better. But anyways, an infected bronchogenic cyst, or presumed.
I don't think I've ever seen a bronchogenic cyst in this location.
I have.
Have other people seen them anterior like this?
Yeah, I have about 4 or 5 cases that are anterior like this. And I just had one.
How about lymphangioma?
Oh, I've seen a lot of lymphangiomas here, but lymphangiomas, I've never seen a lymphangioma get infected like this. And he said there were no he said it literally was just lymphangiomas. They can usually see the vessels coming in and out. And he said, no, this thing was just a walled off cyst. And we'll see what the path shows, but I have seen plenty of bronchogenic cysts in this location.
How about other people? Have other people seen bronchogenic cysts in this location?
Unusual.
I haven't.
I'm not sure if I have for sure.
Yeah,
but you've been at the AFIP, so they get all this stuff. So
and I've seen them de novo. I can pull up a case next week, one I have that's sitting right here next to the PA, that was an infected bronchogenic cyst. Okay. And I have another one I think I might have shown you, but we'll see. Maybe I'm completely wrong, but the surgeon said it was definitely a cyst. But we'll see if there was tumor elements in there, and you know, definitely been mistaken before, but we'll see.
What about thymic cyst? Is its appearance okay?
I just haven't seen those getting infected. So the reason why I'm saying it's bronchogenic versus a pericardial or thymic cyst is only because of its infection, and I've not seen, and not because it can't happen, I just haven't seen anything except bronchogenic cysts get infected. I've seen a couple esophageal cysts get a lot of bleeding in it, but I've never seen an esophageal cyst here.
Got it.
Always seen bronchogenic cysts. The only foregut duplication cysts I've seen in the anterior mediastinum have been bronchogenic. And the mesothelial cysts and the thymic cysts, from my understanding, tend not to get infected. But we'll find out. Maybe they do.
Thank you.
What case is this? I don't remember this case. Let's see here. Let's see what this is. Oh, this is interesting. And this is something that I'm just curious to get your guys' opinion on. So this is a woman who, she has a chest port. She has some sort of, I can't remember what exactly it is, what her malignancy is. But looking up at her, so to me, this looks like pretty classic PLCH. Bizarre looking nodules, some of them kind of forming little cavities around the airways because these little nodules eventually are granulomatous and they cavitate and they start tearing open these airways and forming these cysts. Anyways, what was interesting about it was that she doesn't smoke cigarettes. All she does is smokes a very large amount of marijuana, and that was even what they said specifically in the her notes, is that she smokes heavily marijuana every day. And I don't know if I've seen I mean, it makes sense it happens, but I don't know if I've specifically seen what looks like PLCH occur only with cigarettes, marijuana inhalation. Have you guys seen?
We've seen aspergillus look like this.
Oh, you have?
Yeah, airways disease in upper lungs from marijuana smoking.
I think
marijuana smoking is a aspergillus delivery vehicle. And this is all peri-airway, and it looks like it's upper lung peri-airway.
Yeah.
Seth, some of the people in Colorado said they've seen LCH in marijuana smokers. We don't see much here, but
we're starting to see one, and it's funny. I was showing this to our one of our pulmonologists, and it turns out that UCSD, like, you know how a large chunk of the marijuana industry's money goes to research. Well, I guess the UCSD has a very large building here specifically built for marijuana research, and they have all these grants and opportunities. And I was like, oh, well, that, because I was interested to see, we don't really know what the long-term and even short-term effects of this is in terms of lungs. So we were talking about some grand ideas, but anyways, yeah, it could be. In fact, Dave, you're right. I don't know what the answer is. But you know, I just assumed, but it could be aspergillus.
Yeah.
Let's see what this case is. Again, I just downloaded these a minute ago. Oh no. Well, I'll show this case as well. So another case of a not so subtle lesion sitting in the anterior mediastinum. Yep, big mass, really not a ton else going on, except you look at the lungs and you start seeing a lot of bronchiectasis, a lot of nodularity, so on and so forth. So the patient gets a CT.
Okay, before you say anything, was there a history of repeated infections, or do you know any history?
The patient had, literally, this patient had.
Because I'd like to potentially connect up infections, bronchiectasis, and a mediastinal mass in a certain way, which I think I can if there's a history of repeated infections and bronchiectasis, then one would think of good syndrome.
Right.
Seth, we can't hear you.
Seth, are you there?
There I am. Sorry, I got something that the network was down. Can you hear me now?
Yeah.
Yep.
Okay, sorry. So you're absolutely right. So I saw this, and one of my colleagues was reading it and saw this lesion, and then saw the lungs, and I was like, "Oh, this has to be good syndrome." You know, I'm sure people here have shown cases. I think we've all seen a few cases here and there of. So there looks like to be an infectious bronchiolitis, predominantly in the lower lobes, and then this large anterior mediastinal mass. And I got all excited because I don't think I've prospectively made the diagnosis before. I've seen them or cases of it. So I called up the surgeon and the primary care doc, and I said, "Oh, this guy's got good syndrome." And
Very nice.
you know, they had never. They're like, "What's that?" You know, and I'm like, "Oh, it's immunodeficiency." So literally, this just came back like yesterday or today. Well, you can see the date. So here it is. You can see that. Sure, in fact, he does have an immunodeficiency. And now I'm not really sure, and Howard, you would probably know the difference between the people with, and they did biopsy the tumor, and it was a thymoma. And the question is, at what point the hypogammaglobulinemia associated with thymomas, does that make the diagnosis of good syndrome, or do you need, what else makes the diagnosis beyond having low systemic immunoglobulin levels?
I think that's it, right? That's the paraneoplastic syndrome.
So that's completely it. There's no other, you don't have to meet any other criteria except low immunoglobulins. Okay.
I think so I'd have to go back to find good original article, but
a lot of times they teach that paraneoplastic syndromes are associated with smaller tumors, and not just in the mediastinum, but like lung cancers that may present with paraneoplastic syndromes. This thing's been there for a while.
Wait, so that's interesting. So you're saying that once they remove the thymoma, that the low immunoglobulins will resolve?
I thought it was a paraneoplastic syndrome. I mean, maybe I'm wrong, but
it is.
It's like myasthenia gravis, right? You do a thymectomy in order to help treat the myasthenia.
But usually they still have myasthenia after you remove the thymus. It doesn't, it's not curative for the...
It can be.
Can it?
Yeah.
or at least it gets better.
Okay, well, that's interesting. So anyways, case of, I guess, good syndrome.
I'm surprised that they biopsied it, because the lore around here is if you think it's a thymoma, do not biopsy, because you don't want to violate the capsule and turn a benign thing into something that you've just induced spread in.
It becomes invasive.
Around here they say don't biopsy it if you're suspecting thymoma. The unusual thing for thymoma in this case is how firm this lesion is, how much it's compressing the mediastinal structures. Typically thymomas are soft and they don't actually lean on things.
Yeah, so to tell you that, my colleague read this, and I think there's a differential for this case. I don't, giving the lung findings, I said it was, most likely a thymoma, but he's a young guy. He's 32. Could this be, a malignant germ cell tumor?
Right.
And he just happens to have some sort of infection superimposed or aspirated and went out and partied, or who knows. So I think it is, I have to say, for most thymic lesions, thymic tumors, there's a lot of very avidly enhancing portions with big vessels coursing through it.
Mm-hmm.
But, we know that thymic lesions in younger patients, at least the ones that are malignant, tend to actually be more aggressive. There's a higher rate of thymic carcinomas and, high, even though the AB, whatever, B3 lesions doesn't necessarily determine extent of spread, but those tend to be found in younger patients by some of the big studies. So I don't know if they shouldn't biopsy or not, but it makes sense. I mean, certain things you definitely don't want to induce spread. But anyways.
Presumably they're going to take it out, right? They'll resect this.
Yeah, no, he's going for, they wanted to confirm the immunodeficiency thing before surgery, but he's scheduled for surgery this week.
Super.
All right. Sorry, I went on a long time. Those are my cases.
Jeff, I'll show 2 quick ones. Well, this first one I'm going to show, I have no idea what it is. Well, we have an idea, but I'm just curious if others have thoughts or have seen this before. 21-year-old, this is an MR from yesterday. He's had now 3 episodes of chest pain, troponemia, the most recent one being the last couple of days. And the first 2 times it was attributed to myocarditis at an outside hospital, although in neither case did he really have elevated inflammatory markers. He had elevated troponins, but not that. And then this time he came in with a troponin of over 70, which the cardiologist say, is like basically a myocardial infarction, period. There's not really any other causes. He had clean coronaries. His inflammatory markers, again, were not elevated. And they were trying to figure out what was going on. So we did an MR yesterday, and this is one of the best examples, I think, of edema that I've seen in the lateral wall here. He has reduced function of that lateral wall, not surprisingly, but his systolic function in general elsewhere is pretty good, as you can see here. It's a little reduced. But his delayed enhancement is just crazy. He has just diffuse, predominantly subepicardial enhancement. It's almost circumferential subepicardial enhancement. And then the lateral wall is transmural. Again, clean coronaries the last couple of days, no drug use, no vasospasm. He was just sitting on the couch, according to the note, when he developed chest pain and nausea. And with this pattern, it certainly looks more like a non-ischemic pattern, with the exception of this portion that's transmural. He doesn't have any history or other findings of sarcoid. The one thing that has tipped off the cardiac team is the fact that his mother died of sudden cardiac death. And so our best guess, or really the only thing out of the ordinary we can think of at this point, is that he might have a mitochondrial deficiency. And there are a couple of case reports of mitochondrial deficiencies causing a non-ischemic cardiomyopathy. I haven't seen anything that had great images, and I'm just curious if anyone has any thoughts, because this is just crazy enhancement.
So, Travis, how certain are you that he's not using methamphetamine? Because my son visited here from San Francisco and says that meth is really big in the city, and this is a young guy.
He's young, and they're very certain. That was, of course, my first guess. All of his drug talks have always been negative. Sounds like he's a fairly upstanding citizen, and so I think we're as certain as we can be.
So,
okay.
But yeah, Seth.
You dropped out again.
Yeah, unfortunately, Seth, we can't hear anything. But yeah, I just wanted to throw this one out there. Hopefully Seth will come back with the audio, but there are some case reports of mitochondrial deficiencies, which of course are inherited from the mother, being a cause of like a myocarditis.
You're saying he's had multiple, I'm sorry, I keep losing it, but you're saying he's had multiple episodes of this?
He's had 3 episodes now with chest pain, elevated troponin. This is
how
the most
far
severe. Years. Like one of them was 2 years ago, and that was the most recent one. He was supposed to get an MR at that time, but was too claustrophobic. And then he had 1 episode before that.
I mean, I've seen plenty of myocarditis cases this severe. I mean, that doesn't bother me, but the repeated instances is odd. And
like his CRP and his SED rate and everything else were never elevated in any of the cases. And that was one thing. It wasn't classic for myocarditis from.
No, and you're right. There are a ton of inherited diseases that we know and, injure the heart. And so if his mother died, it's probably something odd. One of these, like you said, a mitochondrial disease.
Yeah.
Well,
okay. Well,
like they're Dannon's disease and stuff, but the Dannon's disease doesn't usually give it like this. It's not this extensive. I don't know.
Yeah, and of course his coronaries. We did a coronary MRA just to make sure he didn't have an anomalous coronary. But yeah, it's interesting.
What machine is that on?
This is I don't remember which one this one is. Yeah, this is one of the best MRAs we've ever run. That's one
Yeah,
of the
okay,
reasons I
because
want to show
that
it.
looks nicer than anything I can get here. That looks like a Siemens machine, and that's not what I
It's
have.
not. It's not. But you can even see the edema on the lateral wall here. But okay, I just want to throw that out there. Yeah, it's going to be some weird inherited thing, and I'll
And its
follow up whenever
pericardium
we
is crazy
actually get.
too. Yeah, that's weird.
Yeah, once we get some information. But I thought maybe somebody might have some insight. Okay, this one I want to show just because there have been some other similar cases. This is I like this radiograph because it's pretty subtle, and I'll give everyone a second to look at it and see what they think. I think that the finding is visible on the PA view and invisible on the lateral view.
Is there an extra bump just above the right hilum or in that area?
Yes, right
That's-
here.
Goes on down.
Yeah, and it extends down, right? And it doesn't efface. You still have an azygoesophageal
Right.
interface right here. So it's this bump here. And so the question is, where is it on the lateral view? It could conceivably be back in here, but you don't see anything. Don't really see anything in the anterior mediastinum on the lateral, other than you don't really see any portion of the ascending aorta or the RV outflow tract. But this is the finding, in fact, and this is the follow-up CT. And it's a subtle anterior mediastinal mass. This was a T-cell lymphoma or T-cell leukemia. It was a recurrence. She originally had a larger mass at one point in time. And so it's not really the histology that's interesting here. It's more just this very subtle right-sided abnormality. So yeah, but you don't see anything on the lateral view. And I think it may just be the absence of any portion of the ascending aorta or the RV outflow tract that you see. But I thought this was a good eye test case to show.
Yeah.
Okay, nice, Jeff. I'll stop there since you and David probably still have stuff.
Okay, sorry about that. I had a phone call. Share my screen here. Okay, let me see here. This is kind of a fun case. I don't know what to make of it. I'm curious if anyone's ever seen this before. So this was done for, I don't remember why, but it's totally unrelated. This is a 32-year-old female, and the only history I know of is an Ehlers-Danlos, and I believe it's a type 4. And what was interesting is her anatomy. So she's got normal lobar anatomy. We're going to come to the vascular stuff here on the left, but what caught my eye right away was down in the lower lobes. Is she's got these funny accessory fissures that seem to almost demarcate the segments of the lower lobes.
Yes. I love it.
Yeah, I figured you would. And there's just a bunch of other accessory fissures and things floating around the lungs. She also has this funny vascular stuff in the left upper lobe that looks like a veno, sort of a meandering pulmonary vein. You can follow it all the way up to the top. And then as we go down right there, it loops around and then swings back this complex connection here and then comes back into the left superior pulmonary vein there. So a meandering pulmonary vein. So it follows the rules. It's got a vascular and a lung abnormality. But I have never seen this many accessory fissures and never beautiful ones demarcating the segments.
Mm-hmm.
Jeez.
Yeah, the only other thing is it says she may have some kind of mitochondrial disorder, but I can't tie it to Ehlers-Danlos and I can't tie it to any potential metabolic type thing. So maybe just unrelated.
Yeah.
Okay.
So this nicely shows how, in that right lung base, how the medial basal segment is like the hub of the wheel. And then the other segments, the anterior, lateral, and posterior, are arranged like spoke-like around that.
Interesting.
So you see anterior basal segment, then lateral and posterior. Maybe we're just saying lateral posterior together or something like that. Mm-hmm. Really quite nice.
Yeah.
So anterior, medial. Actually, we are seeing anterior, lateral, and posterior.
Yeah.
Around and then medially, we have the medial basal segment, the hub.
They are all there.
So, very
Funny
curious.
meandering vein just for kicks. I don't have a radiograph, but very interesting. All
So,
right.
so Jeff, when you were saying meandering, you first said veno. So, do them? There've been meandering pulmonary veins I've looked at that seem to have two venous connections. They seem to arise from a vein and then swing out and then come back to a vein.
Right.
Am I making? Is that what you're implying here
right,
too?
and that they have multiple tributaries. So I think it's just depending on the pressures. It's not that it's a shunt or anything, but just blood probably flows in both directions depending on where the tributaries. But it's all communicating. Instead of a single pipe, it's like a pipe with two inflows or one,
Yeah.
multiple inflows and two outflows, and it just goes wherever both ways.
Got it.
Yeah, but it's not an AVM. All right, this is just a beautiful case that Chris Meyer picked up prospectively. This was done for looking for thymoma and saw this radiograph. And we had radiographs going back like 15 years, and she's always sort of looked like this. And he recognized that this looks like a proximal interruption of the pulmonary artery. There's no pulmonary artery. The lung's small. There's this peripheral cystic stuff here. The other lung has swung across midline, not herniated, but it's just moved across midline to fill the space. And you can see everything. And unfortunately, we didn't have a CT, and there was no plan to get a CT, but she developed pure red cell aplasia, so someone along the way decided she needed the CT too, so we just got lucky. She does not have a thymoma, but what she does have is just a nice example on CT. You can see there's no pulmonary artery, and as expected, the lung's small. She does have another anomaly for fun. She has a cardiac bronchus right there. Also has a big tracheal diverticulum, which I don't know, maybe the fibrosis up here or whatever this is, this abnormal lung led to that, or maybe it's unrelated, because this was purely incidental. But interesting, on some old outside reports, this had been called unilateral interstitial lung disease for a long time. But you can see all the sort of the nodularity along the pleural surfaces, probably transpleural collateral vessels, transpleural lymphatics, maybe, I don't know. But very good example of a proximal interruption pulmonary artery with radiograph.
Did Chris pick up the cardiac bronchus on radiograph?
No, unfortunately not, but I think he'd already hit a home run on this one. So he was so glad, because we didn't think she was going to get a CT because there really wasn't a justification. But then this pure red cell aplasia crept up. All right.
So Jeff, you pointed out that the lung cysts before. What's your rationalization for that? Why did they get this?
I think the lung doesn't develop normally. It's the same thing sort of with like CPAMs. The best analogy I have ever come up with is multicystic dysplastic kidney, where the ureteric bud and the primitive renal mesenchyme don't touch, and whatever cascading event that forms normal kidney doesn't happen. I think of the same thing in the lung. You have sort of this protoplasm lung blob, and then you've got this branching foregut that includes that induces lung formation, and that if perhaps it's not normal in utero, the lung doesn't develop normally, and then over time it's an abnormal lung, because as far as I can tell, they shouldn't be prone to any infection. The airways are normal. It drains normally. There's normal venous drainage. Potentially another possibility is there's chronic. That may be part of it, but I also have cases where the lung is just small and absolutely normal. So the other possibility is that there's a lot of systemic arterial supply, and that the systemic pressures somehow injure the tissue and it doesn't develop normally, or it becomes abnormal. But she's had the cystic stuff for 15 years plus.
Got it.
So I've seen a lot of cases in babies and younger pediatric when I used to do that, and the lungs were normal. And we have cases where over years the cystic stuff develops.
So it may be just the chronic systemic arterial.
Yeah, I always thought it was chronic systemic arterial supply. Charlie always said it was infarcts, and that's why they're all peripheral. I don't know. I don't think anyone really knows, but
yeah.
So, Jeff, do you think there's emphysema on the other side, or does it seem to be a bunch of little holes?
That may be noise. No, there's no emphysema, I don't think.
Okay.
No, she's got a good, healthy lung.
Those little tiny dots of emphysema that Travis showed, and there was, what was it, Pura syndrome or one of those syndromes?
COPA.
COPA.
Yeah.
They're getting testing on that woman. I convinced them.
Oh.
Good.
No, it looks identical.
Here's a
it
case.
literally looks identical.
So this is a great case. I have confirmation somewhat of the diagnosis. I don't have a lung biopsy, but I don't think we really need it. So this patient was being seen for heart failure with preserved ejection fraction, and first underwent a cardiac MRI somewhere else, which was actually quite well done. Not that I'm one to judge quality of cardiac MRI, but let me show you. So on this, let me show, here we go. I never figure how they label these things, but there's thickening of the LV, first of all. If we see that, this is a cine loop here. And you can see, I'll maybe defer to you guys, but not a ton of hypokinesis, maybe a little, I don't know, but it's a pretty thick looking LV. And then they did the other stuff in there. Let me see if I can find, I won't even go into the T2 mapping, but here we go. Here's the delayed enhancement. And you can see just extensive delayed enhancement in the myocardium. And then somewhere in here is it's labeled, is the TI series, where they tried to find the TI. Let me just show another one of the four. Here's the 4-chamber delayed enhancement. But effectively, I'll see if I can find it. It's in the stack somewhere. But when they tried to do the inversion recovery and null the myocardium, it didn't null at all. So, we're thinking amyloid. So, we've seen cases of amyloid before. I don't know where they put it. But what's really cool, I think, is the lungs. And they were looking for sarcoid at the time. And you look at these lungs, and you can see there looks like there's nodules along the vessels, or the vessels, I should say, or septa look a little bit nodular, but it just doesn't have quite that sarcoidy look that we would get. Not clumping of nodules, but almost just thickening along the interlobular septa that's nodular. And you see it along the costal pleura as well. There's no lymphadenopathy, there's pleural effusion and all that. And there may be a little bit of edema in there, but when I saw the MR and I saw this, I'm thinking this is probably pulmonary amyloid. And so sort of a diffuse, and it's a TT, was it the TTR, I wrote it down.
Transthyretin.
Yeah, that one. That's the one they think.
Yeah, and that's
that's the one they think this patient had.
That's what the delayed enhancement looked like too.
Yeah, I don't know. I'll admit I don't know which pattern it looked like, but I asked one of my colleagues, and he quick, like a 5-second response was amyloid, and I think the lungs fit with it for alveolar septal amyloid. And I can't remember if there's a correlation with that and pulmonary amyloid. I mean cardiac amyloid.
Now, I have to say, that's all. It's a beautiful case, and everything looks for amyloid. I have not yet seen a case of, and I've seen a fair amount of amyloid, of cardiac amyloid with pulmonary findings. So that's really great.
Yeah,
it's not great for her, but that's pretty
the weirdest looking edema in the world.
No, it looks like amyloid.
That's what I think. That's what it looks like to me. Yeah.
I was just going to say, I thought the lung was usually light chain as opposed to like AL light chain as opposed to transthyretin, but I don't know that for sure. All
right, last case. So this is a youngish guy. I think he was like 50-year-old, was transferred here. This was for chest pain and eventually something else. So he was seen in an outside hospital for chest pain, and they did a PE study. And the way they did a dextro phase, so all the contrast is in the pulmonary arteries. There's a little bit in the veins, but there's none in the aorta. And they saw no PE, but this big ascending aorta. It's compressing the SVC. There's pericardial fluid here. And that's about all they could say. They sent him here for this aneurysm management. And then he got a CT here. And he had some chest pain still. So we did a non-con first. And you can see that indeed we have some high attenuation material.
So, Jeff, that original study, that's like dissection until proven otherwise, right? When you have an aorta that big and no contrast in chest pain.
Right. Yeah, that's why they sent him here, but they didn't make they just sent him here for aneurysm. And I don't know, maybe they thought dissection, but the history we got was just aneurysm, because they weren't operating on this guy right away, but they repeated the study. And you can see here there's definitely an intramural hematoma. You'd have to worry about that. There's no atherosclerosis or anything else to explain what's going on. And then on our contrast phase study, we always do dual phase for PE and aorta, so you get contrast in both. And you can see there is a defect right there. So it's sort of it's a dissection but not a flap, but I guess you'd call it an intramural hematoma, but there's a communication. There's maybe a little fleck of calcium right on that. I can't tell if that's calcium or not. I didn't remember seeing on the other one, but pretty big one there. And then, he's a little thickened around his aortic valve, but they took him to surgery and replaced it with a valve and a tube graft, and he's doing fine. But this was, I don't think they recognized it as a dissection or as an intramural hematoma at the outside facility because of the.
So is it a bicuspid valve? Is that why it's thickened? Or
I honestly don't remember. I don't think it was, but don't quote me on that. I'll have to go back and look. But it's just a really nice example. It shows the value of a couple things of the non-contrast. Had we not done a non-contrast, I don't think it would have been a diagnostic problem. But also just the fact that when you dump all your contrast on one side, you potentially mix, because I feel like a lot of our PE studies sort of are double rule outs. We seem to get a lot of it.
And I like to call it, we've started calling this like the too perfect PE study, where it looks like your timing is too good.
Yeah,
and it's because there's something
in there, and there's contrast in the left ventricle.
Right, you got to figure out why the contrast isn't getting downstream.
Yeah. So
Jeff, how old is this man?
50.
Huh.
And no known underlying like connective tissue, like Marfan's or something, but I'm sure he'll get evaluated for that because, as you saw, he didn't really have any atherosclerosis.
And not hypertensive.
I think he had some systemic hypertension, but I don't think it was like long-standing and all that.
I bet it's probably a bicuspid valve with that thickening, even though it looks like the sinotubular junction.
You're probably right. I can go look at it. I know they replaced the valve, so we should know if it's bicuspid.
Any hint on the non-contrast that the pulmonary artery wall is involved?
We looked for that, and I did not see that.
Okay.
It's pretty noisy, but
it's compressed.
Yeah.
It's compressed.
Yeah, and even on the contrast, you just don't see. You could maybe think right there, but it's so big, it's hard to tell. I think this is just extrinsic compression because it doesn't go all the way around, and you don't see it on the left.
Yeah.
I just think it's so big, it had nowhere to go. You wonder if there's a little bit, but it's not like the ones we've seen in the past.
Yeah.
All right. Well, thanks, guys.
Thank you very much.
Take care.
See you next week.
Bye.
Bye.